All right, perfect. So we are recording. So this is a slide deck I'm going to go through today. We are introducing the renal system pathophysiology, and then we will get into MNT. So the goal of every, really every disease process we talk about is to talk about normal form and function before we talk about dysfunction and how to medically and manage through MNT. So we're going to I really want to focus on the risk factors and why a person might develop CKD and what CKD is, chronic kidney disease. And then talk about when we know what the kidneys do, then it's easy for us to understand the reasoning behind MNT for chronic kidney disease. So in our kidneys, in our two kidneys, we have a variation of healthy to diseased, and the progression of kidney disease goes through several stages. The severity of different types of kidney disease is different depending on the diagnoses and also depending on the other comorbidities that occur for patients. So there's also what's related to kidney disease is not just renal failure, but things like kidney stones, acute kidney injury that could be like, let's say, a blunt force trauma to the kidney, chronic kidney disease, which is when you have kidney disease that has progressed through the stages. And if it progresses to stage 5, and then you have overt kidney failure, that's when it gets to what we call ESRD, which is end stage renal disease. So we talked about the functions of the kidneys already briefly. So let's go through them a little more in detail. So our kidneys have sort of these 4 main classes of functions. So there's regulatory, excretory, endocrine, and other. In regulatory, our kidneys are helping us balance fluid and electrolytes. They are helping with acid-base balance, calcium and phosphorus, and this is where the MNT application of that comes into play, and blood pressure and blood pressure regulation. We remember the RAS system, renin, angiotensin, aldosterone system, helps to maintain and bring blood pressure back up. This is also why MNT application for sodium is important. It's excretory, so removes waste and excess fluid. The fluids get stored in the bladder, and then they're released when your bladder is voided. The endocrine functions are the formation of erythropoietin, which is EPO, which is really important for red blood cell development, and vitamin D activation and producing renin, as again part of that RAS system. Our kidneys also help with glucose homeostasis. Our kidneys are really important. So let's say, for example, you have type 1 diabetes, you're on an insulin pump, and you get sick, and your blood sugars are starting to run in the 300s and 400s consistently. Our kidneys, our body is really good at then not holding on to that glucose, but getting rid of it. And a big way to get rid of these elevated blood glucose numbers is to get rid of it through the urine. So that's where all those polys come in: polyuria, polyphagia, polydipsia. That's why patients, they get really thirsty, because the body's asking for more fluid so that fluid can help flush out that excess glucose. So in the olden days, before we had really good diagnostic tools, doctors would actually smell urine, and the smell of sweetness it actually means the presence of overt large amounts of glucose in the urine. And they also have urine sticks where you can actually test the urine to see how much glucose is in the urine, and that's indicative of diabetes. So the functional unit, if you remember, of our kidneys is the nephron. There are a lot of nephrons. And I like to think of the kidneys as a large sort of like sponge, where it is filtering, it's taking blood in that has waste products, and it's using this big filtration system to then filter the waste products out into what will develop as urine that then gets voided. So the nephrons continue to work in this way. And then in the waste products from blood, then that gets processed through and then put into urine, and then it's voided so that it's not continuing to recycle inside of our body. The glomerulus is the what allows these sort of like small molecules to pass through, things like urea and creatinine. As we discussed in lab, urea is that byproduct. So ammonia gets converted to urea, then urea has to be excreted. This is the other reason the MNT application for protein is really important when we talk about protein restriction as kidney disease progresses. It also filters larger proteins and blood cells. And then what's formed is ultrafiltrate is what's formed. And the kidneys are not just about getting rid of toxins, but they also help with the reabsorption of some nutrients. So some minerals, amino acids, some glucose, and definitely a good amount of water gets back and reabsorbed. Our body, again, is great at homeostasis, trying to aim for balance, and it's reabsorbing the things that we may continue to need. Please remember, this is really important, the GFR, which is the glomerular filtration rate. The GFR, along with BUN and creatinine, are blood values, blood tests that we use to indicate how well our kidneys are functioning. So what it indicates is the rate of clearance through the glomeruli. So it's telling us that if it's 130 or above, so usually 130, 135 and above liters per deciliter, that means that the kidneys are filtering at a normal rate and you have good, adequate kidney function. So here's a good example of the filtration process looks like. This is straight from one of your, from your book. And I will let you review this a bit more on your own. So the urine solute load is measured in milliosmoles. That is a load that represents end waste products of normal metabolisms. End waste products, so what would that be? Urea, for example, end waste product of the metabolism of protein. The kidneys can, get rid of a little bit of this urine solute load or a large amount. They're very, it's very varying day to day. What happens in kidney disease progression is that you start to make less and less urine. So know these definitions. Oliguria is when there's less than 400 mL per day of urine. And anuria is when there's less than 50 mLs per day. When you get to the anuria place, again, if the kidneys are not functioning, you're getting to end stage renal disease. We start seeing that at end stage renal disease when the urine output of a patient is very, very, very minimal. Think about your average day to day. Maybe you're drinking more water during that day, and you're noticing that you're going to the bathroom a lot more during the day. And some days you're more dehydrated, so your body may be holding on to that fluid and you may not be producing as much urine. That day-to-day fluctuation is normal and it's healthy, and it happens with all of us. The tiny amount of urine and anuria that's produced, that would usually indicate that you need to be on dialysis really soon because your body is not producing urine. And so that means it's not filtering the blood and those toxic metabolites are being built up. This is when we talk about erythropoietin. It's important for red blood cell production. What happens in the kidneys is that you have these bone marrow stem cells from our bone. You have red cell mass that then there's sensors on the kidneys that then know to create more erythropoietin, which then stimulates that red blood cell production. If your kidneys are diseased, then you're not getting the stimulation of an activation, I would like to think of it, of erythropoietin. So then the amount of red blood cell production that is done or completed in the body is reduced. Kidneys are also important for vitamin D activation, and that can also be compromised greatly in the cases of overt kidney disease. Okay. So the GFR is our sort of main lab value that we used to monitor how well the kidneys are working. There's different functional assessments that you can do, and if you're a nephrologist, which is a doctor that specializes in the kidneys, these would be labs that you would run consistently on patients. So there's tests to see how the tubulars, the structures of the kidneys are functioning, microalbuminuria. You can do evaluations of the kidneys through taking a biopsy, a bit of the kidney, to see if the kidney is diseased. And there's also MRIs and ultrasounds that can be used that a doctor might order to see and rule out other issues and disorders of the kidneys. If you have cancer and you have a large mass on your kidney, that large mass is going to take over some of the functional units, the nephrons area. So a biopsy or MRI or imaging can be really helpful in these cases because it can help the doctor see exactly where the mass is, if it's able to be removed, if it's infiltrating other areas in the body. And so these diagnostic tools are pretty key. So when we talk about clearance, we're talking about the volume of plasma cleared of solute per volume of time. So a lot of things in kidney assessment is how much time is it taking to be able to clear toxic byproducts of metabolism in the body. The creatinine that you measure is a critical factor for estimating clearance. And so that's why we run tests like BUN and creatinine. The GFR is expressed, and there's a different range for the GFR in different ages of individuals. As with most things, as you get older, things start to slow down. And the GFR is 1. So as adults get above 45, we allow for the mean GFR to be a little bit higher. And then the serum creatinine stays the same for males and females, regardless of age. But what's important to note is that plasma creatinine varies inversely with the GFR. As we talked about, the GFR, when you go from stages, let's say 2 to 3, and then 3 to 4, we see that the GFR decreases. So it would go from, let's say 70 to 60, and then 50 to 30. What we see in BUN and creatinine is the inverse. So it goes up when the kidneys become compromised. When you have a long-term reduction of GFR, that is what indicates chronic kidney disease. Okay, let's see if I have a question. Cassidy, what I need you to know is that I need you to know the types of labs that we run for patients in kidney disease diagnoses. If I, let's say on an exam, what I'll do is I will give you a lab value for a patient, and then I will give you the normal reference range of the lab value. What I need you guys to be able to tell me is, why is this lab value what it is? Why is it really low? Why is it really high? So that is what I'm expecting of you for this class.
I just have a question.
Okay, so unlike the liver, unfortunately, as our kidneys deteriorate, it becomes progressed and irreversible. So the kidneys cannot bounce back, if you will. So the goal, make sure that you make note of that. The overarching goal is to preserve kidney function. And that can be done with aggressive medical management and aggressive management of MNT. So the stages are stages 1 through 5. Typically it takes time to progress through these different stages. The different stages of the disease require, and as you move through the stages, require even more strict management. So let's say it's because of blood pressure issues, then the physicians would try to strictly manage blood pressure of a patient. And as the stages move through, then the MNT, then the MNT becomes a lot more strict as well. Okay, do you put it in the chat? Do you remember when we talked about we briefly discussed this, causes, just put any causes, why would chronic kidney disease occur? Good. Hypertension, diabetes, uncontrolled blood pressure, uncontrolled hypertension, diabetes. Good. Do you think the prevalence of chronic disease is increasing or decreasing? Okay, a lot of you are saying increasing. Good, that is correct. The reason it's increasing is because the prevalence of obesity and the prevalence of diabetes is increased, and blood pressure dysregulation is occurring a lot more often. So the common and frequent causes of chronic disease are being diagnosed at an alarming increasing rate. Okay, so make sure that you make note of this, is that the most frequent causes of CKD is diabetes and hypertension. Again, I really like to emphasize that it's uncontrolled diabetes and it's uncontrolled blood pressure. So hypertension is elevated blood pressure, I know, but a diagnosis of diabetes does not mean you are going to be on dialysis. That's what I really like to emphasize with my clients, my patients, is that with strict tight glycemic management, that kind of diabetes strictly managed is not going to lead to end-stage renal failure. When diabetes, regardless of type, type 2, type 1, when it's uncontrolled, and this is it's not over a period of months, it's over a period of years. When it is uncontrolled, it is causing that inflammatory response inside of the blood vessels. And that overt damage can lead to a blockage of the blood vessels, which means there's not blood flow in and throughout the kidneys, and that can cause damage. There's other reasons we see chronic kidney disease, but they're much less common. So you could have an inflammatory process of the glomerulus. You could have congenital issues. Some babies are born with just one kidney or have 2 kidneys, but they have congenital defects around their kidneys, so they're not functioning. You can have consistent inflammatory processes, and then a neoplasm, which is a tumor inside the kidneys. So fortunately, the highest risk factor as far as individuals are actually African-American men, African-American men with diabetes. A family history of chronic kidney disease is also an indicator. So genetics are definitely at play here for the development of kidney disease. If someone is a heavy smoker, that causes a lot of vasoconstriction and inflammation, which can cause kidney problems. You can have what we call acute renal failure if you had like a direct, let's say you were in a car accident and you had multi-system organ failure because of the car accidents, because of multiple injuries, you could go into what we call acute renal failure. Individuals who rely on over-the-counter pain medication, but usually when they get to the level of abusing it, you can see that that can be a risk factor for developing kidney disease. And obesity, question mark. The question mark is really because does a patient with a high BMI, does that mean that they are directly at risk for developing kidney disease? From the research I've read, that the answer to that is no. But what happens if a patient has a high BMI, and then they have all these other factors surrounding that, metabolic syndrome and these different disorders, that eventually is what can lead to kidney disease. Okay. Anemia of chronic disease, especially if you have chronic kidney disease, majority of these patients do struggle with anemia. For like the obvious reasons are because of bone marrow failure, because of the lack of erythropoietin production. So your kidneys are not producing EPO at the rate that they should. So then you're not having these beautiful red blood cell production like normal. So that's one of the main causes of anemia in chronic kidney disease. It's can also be due to low iron intake, because as the kidneys start to fail, start to become more and more diseased, we're asking patients to restrict protein intake more and more. Can you get iron from other things? There's ways to get iron that isn't like relied on animal source protein, but that is definitely a large component to most diets. You also have increased losses, GI bleeding, and for these patients who are having, they have to see the doctor often when your GFR starts to become really low and compromised. So you have frequent blood draws. You also, if you think about if you get to the place of hemodialysis, those patients struggle with anemia too because of the way that hemodialysis works. And then you can have a destruction of the red blood cells from that circulating uremic waste, which is that byproduct of waste of metabolism that is circulating rather than being voided and eliminated. So what this causes is iron deficiency anemia. And I like to think of it as anemia as related to chronic disease. So to combat that, we can increase iron consumption, PO. There's also EPO can be administered. It can be given to individuals, as well as just dietary iron supplements that are just little tablets that you take with water. Okay. What can happen with this chronic kidney disease is what we call secondary hyperparathyroidism. And this is when you have an overstimulation of the parathyroid gland. These consequences can progress to be severe and lead to bone disease, which then compromises the integrity of bones, the mineralization of bones, and can lead to more things like fractures. What we give for MNT management of this is restricting. This is why we need to restrict dietary phosphorus. And you can also give patients something called phosphate binders. So when they're consuming food that has phosphorus in it, these binders are actually really big. They're like big horse pills. You can take these binders with food and it'll bind phosphate and then remove it. And then also giving supplemental vitamin D. I think I have a slide. Here it is. Here is the way that I like to think of this visually. And I think that I feel like this is helpful. Okay, let's see if I can draw some little lines. Okay, so what we have is, I missed my drawings. Oops, my drawing. Okay, move this out. So you, why can't I just move this? It's just like right in the way. That's not helpful. There we go. Ta-da! So smart. Okay. Here's what happens. The main thing that's happening here is that you're having a drop in plasma calcium. That's why the star is right there. So what happens is calcium, the plasma calcium levels drop. That signals our parathyroid glands then to secrete more parathyroid hormone. When parathyroid hormone is secreted, there's a cascade of things that occur. So you'll have the kidneys will then increase the reabsorption of calcium in the kidneys, and they decrease urine excretion of calcium. So calcium drops, your parathyroid glands secrete parathyroid hormone. That indicates to the kidneys two things. One, reabsorb the calcium. So let's keep it on board because we know it's low. And two, stop getting rid of it. So we're going to hold on to it and we're going to stop getting rid of it. That is what the kidneys normally do. In our bones, the parathyroid hormone tells our bones to mobilize, that's this part here, calcium from the bone. So the kidneys are reabsorbing and holding on to calcium, and the bone is sending out calcium. Those two things here, the goal of it is to then increase plasma calcium. The kidneys also, that's 1 and 2, here's 3. The kidneys also increase the activation of vitamin D. And what happens there is that in the intestines, there's an increased absorption of calcium in the intestines. So I want you to remember this. So the kidneys, this is why they're so important in this area. The kidneys, number 1, reabsorb calcium. Number 2, they hold on to calcium, so they stop getting rid of it. And number 3 is that they also increase the activation of vitamin D, which then in the intestines increases absorption. All of these things, all of this cascade of events is essentially trying to basically get a low plasma calcium to go back to a more normal level. It's kind of like the RAS system. The whole cascade of systems and activations is because the blood pressure is low and goes through this whole cascade of events to get blood pressure back up. And this is what's occurring when the plasma gets low. There's this cascade of events because of the parathyroid hormone that then utilizes different parts of our body, but really heavily focused on the kidneys to increase plasma calcium. Okay, let me get rid of my beautiful drawings. They're all drawing. Look how easy that was. Okay, so let's talk about what happens in renal dysfunction. Calcium plasma levels drop. The parathyroid hormone secretes more, the glands secrete more parathyroid hormone. Does this happen in any, okay, good question. Does this happen in any particular order? I like more to think of it as a cascade of events. They're sort of occurring at a very similar rate. So when the kidneys, so let's, if the kidneys are then starting to become diseased, where's my drawing? So kidneys, you can just write a really sad face emoji. The kidneys are really sad. They are not functioning like they should. It's a beautiful drawing. When the kidneys are sad, they are not allowing this cascade of events. So the reabsorption is not occurring here. Activation of vitamin D is not occurring here. And then as a result of that dysfunction, the bones are being relied more heavily on. And so then the body is mobilizing calcium from the bone at a rate that is not normal. And that is what leads to, let me see this at the bottom here. What we call renal osteodystrophy. And that's the reason I showed you these slides. To make sure you have a good functional understanding of why, basically, what should be happening. And when it is not happening, what is the result? So then what happens is the bones are being mobilized at a rate that's not appropriate. And that is leading to the sacrifice of the calcium content of the bones. This makes the bones more brittle and more likely to break. What we also have is what we call, this was called renal osteodystrophy. And you also have what we call secondary hyperparathyroidism. And this is an activated response due to the renal system becoming more and more diseased. So what you'll see is a reduction in serum calcium and an increase in serum phosphorus. That triggers the body to release more parathyroid hormone. And what that does is it decreases calcitrol, increases bone turnover, and decreases renal reabsorption. That, excuse me, you'll continue to see a decrease in serum calcium and an increase in phosphorus, and that leads to these secondary systems occurring. What I want you to do to understand this better, I'm not in love with this slide as much as others. I have I have something that I wrote out on the whiteboard that has a better description of what this is. And there's also a video that's posted on Canvas that describes in detail secondary hyperparathyroidism. Okay. I'm not going to spend any more time on that just because we got to get through these slides. Okay. So cardiovascular disease is really difficult to manage for a lot of patients. And that's why I talked about the lifespan of an individual with renal disease. A lot of it depends on the other comorbid conditions that are occurring. So cardiovascular disease can be caused by inflammation because there's this inflammatory process that is occurring. It also, because the kidneys are so important in regulating calcium and phosphorus balance, when they are chronically imbalanced, that can cause what we consider vascular calcification, and then that hyperparathyroidism. The other issue here is in chronic kidney disease, a lot of these patients have hyperlipidemia. So a lot of patients who present with chronic kidney disease also have elevated LDL, total cholesterol, and triglycerides. So you could have CVD and then have chronic kidney disease start to occur. You can also have chronic kidney disease start to be diagnosed, And as a result of a lot of the inflammatory processes and imbalance of certain nutrients, that can lead to the vascularization of the cardiac function become more compromised. And that is why it is the #1 cause of death with patients who have chronic kidney disease. So patients with GFR that is dysfunctioning and kidneys that are starting to deteriorate, a lot of these patients are more likely to die from cardiovascular disease, CVD, than progress to stage 4, which is right before stage 5, which is renal failure. This is especially true as you get into the patients who are in a much older geriatric age, and exacerbated if they had issues with their cardiac function even previous to developing kidney problems. So because we know that this is such an issue for our patients, the TLC, you guys remember the TLC diet? It stands for therapeutic lifestyle changes. A lot of patients are put on a diet that is moderate to lower in fat, that includes a good amount of our poly and monounsaturated fatty acids. And saturated fat is really encouraged to be decreased about 7%. The other thing with the therapeutic lifestyle changes diet, the TLC diet, is that it's very high in fruits and vegetables. So it's also very high in fiber and micronutrients. Okay, so how do we assess kidney disease? Again, this is a super important slide. I need you to memorize everything that's on here. And this is really how we stage the progression of kidney disease. So, question in the chat. Let's see what it is. Would we use that MNT for? It's like our case study. What?
I meant patients, sorry, for patients, like our case study.
Can you say that question again?
I meant like patients for our case study. Like the
Are you talking about the
diet?
TLC diet?
Yeah.
When we talk about the case study and you focus on MNT, the slides that I'm going over on Thursday are going to be really helpful.
Okay, thank you.
Is that your question?
Yeah.
Okay, so we have the different stages, and depending on these different stages of kidney progression, disease progression, the amount of strict MNT and also medical management of blood pressure or diabetes, if that's the case, becomes much more strict and rigorous. So again, the goal is to stop the progression of patients from stage 1 to 2, 2 to 3, 3 to 4. If we can get patients at the very early stage of stage 1, where the GFR is starting to decrease a little bit, that's when we can do some really aggressive, that's a great time to go see a dietitian, someone who specializes in these kinds of MNT management. And the other thing is, some patients don't know that if they don't control their blood pressure, that could lead to deteriorating kidney function. So education is about nutrition, but it's also about management of whatever the underlying issue is that's causing the deterioration. So what we'll start to see with patients who are progressing through the stages of 1, we don't see this quite as much in stage 1, but definitely as the patient progresses through stage 2 and beyond, is that you'll see sodium retention, and you'll see like the patients are holding on to fluid. And what they will present with is elevated values. So you'll see hyperkalemia, hyperphosphatemia. So the phosphate is not being balanced and cleared. And so it's elevated in serum. We may see some acidosis because of the importance of acid-base balance in the kidneys. You'll start to see the urine output decrease. And I don't know if you've been in the hospital and seen those, if a patient is in the bed, and let's say they're in bed and they have a fully catheter inserted, that will be voided into a bag. And a lot of times doctors use that to measure the urine output daily to see how well the kidneys are functioning. We'll also see things like anemia, and then bone and mineral disorders, as we talked about previously in a couple of slides before. So in creatinine, for males, the normal range is slightly different than females. And again, with creatinine values, these levels go up in patients that are experiencing progression of kidney disease. We also can see that if dialysis does not remove enough of those toxic metabolites, then the creatinine levels may stay high. You'll also see that increase with dehydration and catabolism, and also if the muscle mass of a patient is low. BUN is another lab value that we use for assessment. So with BUN, the normal is like 10 to 20 milligrams per deciliter. The goal really is to keep it less than 50 in chronic kidney disease. And you may see the BUN increased in things like renal failure, dehydration, in malnutrition, or in a really high protein intake. So again, in renal failure, so in kidney disease, creatinine and BUN will be elevated. You might see BUN be low protein intake if dialysis was overly aggressive and pulled off too much, if the patient's overhydrated or in liver damage. Thinking about why that might occur in liver damage. So in liver damage, remember when you see the damaged liver, especially if it's becoming scarry and cirrhotic, that's cirrhosis, things are not being detoxified and moved through. They're just basically, it's not functioning, so it just stops sort of the output of it. So with BUN and creatinine, we see that there's sort of like a ratio that is given, and then when you're running blood tests, the values will be BUN to creatinine sort of ratio, and so you'll find that these are the values that are listed for pre-renal, and then when we see renal damage. But just remember that in renal disease, the GFR will decrease and the BUN and creatinine both will increase when we see intrinsic aggressive renal damage. Doing on time. Okay, perfect. We'll also have to monitor sodium, magnesium, and calcium. We see that sodium levels will be altered and sometimes difficult to manage. Magnesium may be increased in the late stages of chronic kidney disease. And in calcium, oh, here's my beautiful, as I promised. In calcium, you can see calcium decreased with renal dysfunction due to the decreased activation of vitamin D. And that goes back to some of the slides previous that we were talking about. When you have calcium values, the calcium levels need to be corrected if albumin levels are low. So again, in your case study, I think this was question 1 or 2, this is how you correct. So you'll take, it's an easy short equation. You'll take the serum calcium level. Let's say it was 10. And then you're going to add it to what is 0.8 times 4 minus the serum albumin level. So take 0.8 times 4. So 4 minus the serum albumin level, then multiply that by 0.8. And then you'll add that. Oh, excuse me, allergies today. And then you'll add that to this to the serum calcium level. Okay, you used an online calculator. On the case study, will we need to know the equation for the midterm? You need to know this equation. So simple equation. Basically, you're taking the lab value from calcium, which will be given, and the lab value for albumin, which will be given, and you're going to plug it into this simple equation. What it usually does is it adds back a little bit of value to the calcium level, because calcium, albumin is that big carrier protein that helps to carry calcium. So we want to make sure that we are understanding the appropriate value of calcium, what it actually is, because it can be erroneously low. So use this for your, I know there was a calculator that you could use for this. I wanted you to go to the DaVita website. I wanted you to go see all of what the access they have online. But I do want you to know this equation for your exam. Okay, this is the reason we have to monitor potassium so strictly, is that in renal disease, potassium goes up. So in renal failure, we see that you have increased potassium levels. And so as the renal disease progression continues, you will start to see, a strict reduction in the amount of potassium that is allowed in an individual's diet. The potassium can also be high due to other things like trauma or infection or dehydration. But you're definitely going to restrict potassium if the urine output becomes really compromised and low. With phosphorus, again, this is why this other mineral, because calcium phosphorus balance is an important regulatory function of the kidneys. Phosphorus, you will see this increased. Phosphorus is remaining in the serum blood. So you'll see it increase with renal failure. And that is, again, why as the kidney disease progresses, phosphorus needs to be restricted, or you can take phosphate binders if you're consuming foods that are high in phosphate. Okay. I'm going to skip that question for the sake of time. What with hemoglobin and hematocrit, this is a really big indicator of anemia. And you'll oftentimes see in both males and females that the H&H will be low. And that's due to anemia of chronic disease. It's also due to blood losses. Also, we see these are low due to the compromised decreased production of EPO, so then also decreased production of appropriate amount of red blood cells. So in acid-base balance, you may see the patients become somewhat acidotic. So that's closely monitored. It's also acid-base, the pH is closely monitored in patients who are undergoing hemodialysis as well. And in protein, what we'll see, the serum albumin, you might see proteinuria, which is protein in the urine. So this is when your urine protein is elevated. And these protein losses can contribute. There's a whole host of reasons why albumin will be compromised in patients with chronic kidney disease. But you can also see losses of protein in the urine. Okay, perfect. We got through, is it my last slide? Great. Okay, we have a little bit of time. I want you to, I'm going to put you in breakout rooms. And I want you to, where did my thing go? Talk about why renal osteodystrophy occurs and why anemia is common, and 2 factors that contribute to cardiovascular disease. This is the last slide. I'm done lecturing. Do you guys have questions? You want to just ask me now? I stopped the record. No, I didn't. Did I? Am I recording this still? Good Lord, I am. Stop.